We'll just start in a minute. I'm just waiting for a few more people to join. Well, welcome to the C3AI Digital Transformation Institute Colloquium Series. C3AI DTI is an institute that was formed to attract the world's leading scientists to join in a coordinated and innovative effort to advance the digital transformation of business, government, and society. As you can see, it is a consortium of leading universities and industry, mainly supported by C3AI, but also by Microsoft. This is part of the colloquium series. Today, we'll have a special speaker from our own university, University of Illinois, but we will be having weekly colloquia afterwards. And these are some of the titles you'll see. A lot of them have to do with COVID-19, which is still with us, but others have to do with machine learning more generally and deep learning in particular. And some have to do with applications of deep learning outside of this area. Just take a look at the very interesting and varied talks that we're going to be seeing. And we will have more coming in and we'll be updating this list every week. So this is, there's a YouTube channel that I recommend you take a look at because you can see the previous colloquium talks as well as other events that we've had. Very interesting stuff. And if you need to get the connection, it's linked right here, but you can also ask us for it. Today, as with the other colloquia, we have a 40-minute presentation, at the end of which we'll have a 15-minute Q&A period. You should be using the Q&A feature to ask questions. I think that may be the chat, but make sure you put your questions into the box and we'll be asking them. If you see a question you like, you can upvote it and we will answer as many questions as we can at the end. And if there's still questions you wish to ask, you can forward them directly to the speaker. So today's speaker is talking about modeling and managing the spread of COVID-19. And he's, as I said, one of our own colleagues. He's an assistant professor in the Department of Electrical and Computer Engineering here at the University of Illinois. His research is in the area of power and energy systems and is geared towards enabling the integration of renewable and distributed energy resources in the modern power grid. He's interested in developing rigorous analytical frameworks, fast algorithmic architectures, and efficient market designs to help enable that integration. I'll add that he came here in 2016 after a postdoc at Cornell and a PhD earlier at 2014 from Caltech. So from Southern California to Northern New York State to here. And I'm gonna pass it over now to Dr. Bose, and thank you for joining us.
Hello, everyone. Hope my slides are visible. Okay, so thank you for inviting me to give this talk. This is some of the work that we've been doing thanks to our sponsor, C3AI DTI. As you may have realized that my work is in power and energy, which is very different from the topic of today's presentation on modeling and managing the spread of COVID-19. This particular pandemic, as of today morning, has claimed 429,000 American lives and a lot more worldwide. So even though I work in a very different area, a team at Illinois here, we started thinking about what can we do as to help in combating this disease. And since March or so of last year, we started thinking about some of the questions that may arise. So today's talk is geared towards sharing what we've done so far and a lot more to come. So without further ado, this is our team. As I said, this is a sort of an effort from non-medical personnel. And thanks to Seshadri from the Geese College of Business, who was instrumental in forming this team with Anton, Ujjal, Yuchian, me, and with our very dynamic postdoc, Sebastian Souyris. Since then, the group has expanded, and now we have Dr. England, who's an epidemiologist, and also Erin, who's from the Geese College. And over time, we started even working with Ronald Watkins, who is currently the director of the UIUC SHIELD program, which started doing this very rapid bulk testing of individuals here on the campus to enable reopening of the institution. So in what follows, I'm going to describe some of the work that we've been doing and also take you through a little bit of the history of how it progressed over time. Okay. So when we first started this, there was a request to us from sort of university administration to help the state of Illinois in thinking about how do you allocate test kits. So this is when test kits were even testing capabilities were just being ramped up at that moment, right? So we developed a sort of a demand prediction model. By demand here, it's how many cases you have, COVID cases. And by the way, these are some of the original slides. So I've kept these dates, etc., are from that time. This is around the month of May and June. So you could create county-wise demand prediction given a collection of potential test sites, and you give me a number of tests and some practical constraints, such as you don't want people to drive more than, let's say, 80 miles and so on. Then how do you allocate test kits? How do you select some of these sites, and how do you allocate test kits? You can write down a simple optimization problem. And we visualized it, and here are some of the results. So we started looking at sort of these kinds of questions that are at the intersection of sort of information sciences, optimization, and trying to think about essentially management of this disease through non-medical interventions. And how can we help in sort of thinking about this entire decision making that goes along with it, right? And so we upgraded that to even do something with a dynamic allocation scheme. As you keep on predicting more and more, how do you keep on evolving your test allocation, etc.? So we developed that, right? But then at this time, when we started thinking about this, as you're testing more, you're also isolating them. So they are not going to contribute to the disease spread anymore. But if that was the case, why were we not being able to contain? And so we sort of started asking this question amongst ourselves: what is really going on? Why aren't we able to contain this disease, right? So this is sort of a rough way of understanding and what went through our mind at that point. Well, if you think about the curve over time of how many are testing positive, right? Perhaps the actual number of infections were perhaps much higher than that, right? And this difference is this unobservable, right? Because you're only testing a portion of the population. You're not testing everyone, right? I would argue if you could test everyone at one point in time, you could isolate everyone who tests positive, and then you can arrest the spread of this disease, right? So essentially, we are paying the toll of not being able to do that, right? There are some estimates as of, for example, in Italy, at some point, their number of positive test cases was around 200,000. Some estimates put the number of actual infections to be north of 2 million, right? And there are papers that came out, this is from like a New England Journal of Medicine, that perhaps the real trouble with this particular disease is its asymptomatic transmission. Compare COVID with Ebola, which has a whooping 50% or so, perhaps even more, of mortality rate. COVID is much lower, but what it lacks in its mortality rate, it makes up for the number by affecting a lot more. And perhaps the way it surreptitiously spreads because of perfectly asymptomatic transmission, therefore, if you were to model the spread of this disease, one needs to account for explicitly this asymptomatic nature of the disease, right? Then we also realize another aspect. From a sort of a controlled dynamical system viewpoint, you think about testing as a measurement device, but it's not really, right? It's also an actuation here. Because if you can test someone and they come out to be positive, you isolate and then you stop them from spreading the disease further. So it's not only your eye, but also a muscle into controlling the disease, right? And at this point in time, when we started looking at these kinds of designing sort of an epidemic model, most of us were under either partial or full lockdowns. So mobility does affect, right? Mobility affects how many people you meet. And hence, if you could, you need to be able to model that in whatever nature of model you use, right? So this gave rise to sort of motivated us to design our sort of own model. I had briefly during my grad school years looked at sort of these the epidemiological models that are these so-called compartmental models, SIS, SIR, ACIR. But we realized that this is somewhat different. You have to sort of account for the fact that there may be people who never show any symptoms, yet they are carriers and they are transmitters of the disease. So to do that, we sort of came up with 4 categories of people with respect to the disease. One are susceptible. Infected, we broke it into 2 categories: untested and then who are positive. And then there are removed, which collects people who have either recovered or who have ultimately succumbed to this disease and died, right? Now, if you think about these 4 categories, there are 2 kinds of epidemiological models one can write. One is this sort of agent-based model, right? So think about these 4 categories. If there are n people, there are 4 to the n states. So then you try to analyze the Markov chain on these 4 to the n states, right? That's sort of these sort of the agent-based models where you try to essentially simulate in some sense how and track this sort of the propagation of the disease in and try to create almost a digital twin, if possible, as close to the reality. The other option is to go through these compartmental models. These are sort of simplifications, and these are sort of quote unquote mean field models, you can think about them as, which tracks the sizes of the different population segments. So if there is some number of people in these categories, how does that number change, right? So we essentially try to write down our own models. And by the way, there are multiple models that came up. So we wanted to sort of, this is a sort of a delicate dance between modeling exactly what the reality is, but also keeping the model parsimonious enough so that you can derive some structural insights, right? So we wrote down this kind of a simple model where on day T, we consider a sequence of events, and then we encode this event sequence into a dynamical system model here. So let me just quickly walk you through some aspects. I don't want to give too much notation and so on, but we consider 3 kinds of testing. First is symptomatic individuals. So notice that, I mean, back in the day, most of the testing was limited to symptomatic testing. Then we also looked at contact tracing. So contact tracing is becoming popular when we started writing this model. Then also random asymptomatic, right? So you first test, but don't release results. Then you allow the population to mingle. Here we specifically consider the susceptible and the untested population to mix. You can consider a little more complex versions as well. And then, and how do we model that? So let's say that each untested individual meets around FT people, right? So if UT number of people meet FT number of people, right? Out of them, this fraction, ST over ST plus UT, would be the fraction of people who are susceptible contacts, right? Among them, let's say beta fraction of them get infected, right? You can think of beta as the probability of transmission. And then, so these many people will now have to be migrated from the susceptible box to the untested positive, right? But then after this, test results arrive, and whoever tests positive, that number is phi of t. You move them from the untested to the positive. You add them. Make sense? After this, you allow a particular constant fraction of people who are in untested or are who have tested positive to recover, and so that's gamma fraction. And so you keep track of that in this. Then you write down the dynamics, and you can write that down as follows, as given here. Now let's parse a little bit more of this phi of t. We consider 3 kinds of testing, as I said: X being symptomatic, Y being contact tracing, Z being random asymptomatic tracing testing. So how do I get to numbers like phi xt? Just to give you one example. So remember that we have like susceptible and infected. Not everyone is symptomatic. So think about some portion of the susceptible being symptomatic. By the way, susceptible symptomatic means essentially you have cold or flu-like symptoms, which can be confused with COVID-like symptoms. right? So the total number of susceptible population, total number of symptomatic population will be an addition of this orange box and this orange box from the susceptible and the untested. And then, so that number is psi of t, out of which alpha I ut are the numbers that are actually COVID positive. If you were to institute XT tests, the number that will come out positive is XT times this fraction, roughly, right? Again, this is all just average numbers tracking, right? And of course, you cannot have more number of symptomatic individuals testing positive than there are actually in the population. So it's a minimum of these two. So that's how these kinds of models are built. So you have to do a little bit of bookkeeping. I'm not getting into all the details of how this is formed. This is given in a working paper that I'll share the link of. But ultimately, you arrive at a model that looks like this. Okay. After that, you take a sort of a large population approximation, and then divide all these SUPR, the number of people, by the total population. Then you get into capital S, capital U, capital P, and capital R, and make an approximation that the susceptible portion of your population at any point in time is still close to being the total population. So you stop tracking the dynamics of S and you track the dynamics of the rest. And you write these down as these are all now in terms of fractions. So the way the model is written, here we have 4 control levers. You can allocate some tests, capital XT, capital YT, capital ZT. These are the fraction of the people who are being tested through the different channels, and there is a mobility ratio. This mobility ratio, think of capital FT being 1, when if you don't have any lockdowns, no restrictions on movements of people. It's 0 if there is complete lockdown, which is of course impractical, but somewhere in between. So it's a ratio that you can do. Now, the quintessential question that people can ask with these kinds of compartmental models: when will the disease asymptotically disappear? Now, consider some static testing and lockdown policies. Then without any testing, the disease can magically disappear if the following condition is true. Now, this comes from a very simple kind of eigenvalue analysis of this linearized system. So without any testing, it can disappear. And this encodes basically the idea that the rate at which new disease is being formed is less than the rate at which it recovers. Now, if you populate this with just some numbers, the estimates from the early literature on COVID-19, this is, again, these all estimations are due to my collaborator, Ujjwal Mukherjee. You quickly see that there is no hope of the disease disappearing without any testing or any lockdown. With capital F equal to 1, you won't be able to satisfy this. Well, okay, can we do something more? Can I increase to symptomatic testing alone and can get rid of this disease? Well, what essentially happens whenever you add channels of testing, you keep on increasing the right-hand side. So keep on increasing the right-hand side, which means that now the restriction on what capital F has to satisfy. Remember, larger capital F means less lockdown, right? So it essentially buys you, testing buys you more an ability to not lock down to the same extent. Make sense? So with perfect symptomatic testing, this right-hand side gets pushed a little bit by alpha I. This is the fraction of the population that is symptomatic among COVID positive individuals. And these numbers, if you take, let's say, 0.6, you will again quickly realize that without any lockdown, this is also not going to work with sort of the rough estimates again. Can perfect contact tracing help you? If you do perfect contact tracing, then these numbers become the right-hand side somewhat becomes competitive with this. Now you're starting to look like, well, you can get somewhere, right? But this is with perfect contact tracing. Is perfect contact tracing even practical? Perhaps not, right? So once you even consider contact tracing of efficiency, let's say 70%, and naively just multiply this by 0.7 and so on, you start realizing that this becomes again very difficult without any lockdowns, right? Then can there's a slight mistake here. So with perfect symptomatic testing, perfect contact tracing, plus if you add random asymptomatic testing, that is, you are picking randomly some asymptomatic testing, then it buys you an extra factor of this. So the amount of fraction you push to get tested through this asymptomatic channel, that will then allow you to be able to make the disease disappear asymptotically. Make sense? So this factor, notice that I can make this as large by using Z somewhere close to this alpha S bar. I can make this right-hand side as close to, as large as possible, right? So then in theory, I can. But this is not sort of, this is not very surprising, right? Because if I could do a lot of testing, as I said, if it was possible to test everyone on one day, let's say suppose we could do that, we could arrest the disease spread the next day, because we will isolate everybody who's positive, right? It's our inability to test everyone that would be problematic. Now, with almost no lockdown, how much testing is required? And again, Ujjal's calculation shows around, if I recall correctly, 15 to 20 million tests every day throughout the United States. That's roughly what is required. But if you think about it, that testing, let's do some back of the envelope calculations. Let's use the saliva-based testing regime that that UIUC has instituted. I'm told that it costs around $25 to $30 a test. Now, if that even has gone down, is what my understanding is. So even if you consider $25 a test, and you're looking at, let's say a number like 15 million tests every day, and you ramp it up to be on for 250 days, you will get numbers close to $100 billion. It still pales in comparison to the north of multiple trillion dollars that have been put in trying to combat this disease. So testing might have been one of those channels. It's again, not just the eye, but a muscle to control the disease. So it's very, very simple analysis from just static lockdown and testing policies give you that testing, if it could have been ramped up to a certain extent, would be able to. Perfect. Mind you, when we started this research, all testing was mostly symptomatic. Then contact tracing became somewhat popular. Then it's much later that people started talking about, can you do random asymptomatic testing? Now, asymptotic decay of a disease is, of course, great, but that's not the only thing one cares about from a policymaker's perspective, right? As I said, you could lock it down for a while, and yes, you will get rid of the disease, but that's impractical, right? So from a policymaker's point of view, if you think about what is the cost that the society bears because of this disease, it's really a combination of four things, right? One is perhaps the death toll at the end of the horizon, the economic consequences of lockdown, cost of caring for people, the hospitalization costs, etc., and the testing costs, right? Now, from at a very high level, if you think about these four different things and you add them up and you define sort of this hypothetical cost of testing, this sort of this mode of thinking requires somewhat a centralization, or I would argue that a government is necessary to think about these kinds of problems, right? Because if you think about any other institution, these kinds of four different things that we think about as impacts, no one cares about all of these together, can care about to that extent. If you're a hotel chain, for example, you care about the economic consequences of lockdown, right? If you are hospitals, if you're a hospital chain, you're perhaps worried about the load of people or your ICUs and the hospital beds and your staff. You're thinking about controlling this. So it's only at a policymaker, at a federal government or a state government level is when you can consider these kinds of costs. And we have attempted to write this down in a very simple manner. What we are able to show is that if you assume perfect symptomatic and contact tracing, then the optimal lockdown and random testing sequence over time to minimize this cost function is extremal. That is, if you have some notion of, let's say, no lockdown, and you can only lock it down to a certain level, that can't be zero, right? I mean, let's say you can bring it down to 70% or 60%, and you have some random testing capabilities. Let's say zero is your bottom. Let's say you can do 2% of the population or 5% of the population. what our results suggest is that you will never do half measures. At each point in time, you would like to takes one of the extreme values of both these variables. Sense? So then there are 4 possibilities at each point in time. If your time horizon is capital T, let's say we considered 120 days for these illustrative examples, 4 to the 120 possibilities, that's quite a bit still. So we looked at some basic suboptimal policies. None of them proved to be optimal in all possible ranges of values that we tested with. Some were static policies. We did a receding horizon control. You just look at minimizing costs over 7-day time periods at these extreme values, or you consider one switch, and none of them proved to be better uniformly for all ranges of your transmittivities, etc. But I would like to, and the paper link is given here, but what I would like to talk about is one weird example, perhaps, that we observed from this, and we are quite keen to understand more about this, is this last diagram. Notice in this case, our controller essentially chooses the following. It fixes the amount of random testing to some level, that's the max, over the time horizon. But for the lockdown, it chooses between the max and the min, and it's almost a periodic function. So it's switching between full lockdown and no lockdown, full lockdown and no lockdown, as if in a periodic manner. And notice what happens to the untested population, right? It sort of neither grows nor decays, right? This periodic lockdown scenario, we are interested in understanding this a little more. There are some examples of places where actually my home state in India, West Bengal, has instituted something similar to this. I've been told even Malaysia has enacted on this. And there are even researchers from, I think, Harvard, who have come up with some ways of advocating this kind of a periodic lockdown and no lockdown style policies. We are interested in thinking about, and this seems somewhat practical if you don't know the time horizon, right? We have considered 120. What happens if, I mean, it hasn't disappeared in 120 days. Since March, it's almost about to be next March. So this when time horizon is not known, perhaps this is one way of thinking about going about how to control this epidemic. But a lot more analysis on this we are keen to proceed with. So that sort of wraps up my first part that we have done. And this was for the large population. We're thinking about writing a model and analyzing what control strategies we might be able to institute to control the spread of this epidemic. So at this point in time, we also started interacting a lot more with Ron Watkins, who is the director of the UIUC SHIELD program, as I said. And the question that, I mean, UIUC adopted the paradigm where we are testing north of sometimes to the order of 10,000 people, staffs and students combined every day almost, right? Within a 50,000 population, an institutional population for us. So we wanted to understand, is this sort of what we need? Is bulk rapid testing? Is that the paradigm that one needs for designing some reopening strategies? What are their limitations, etc.? We wanted to analyze. So we wanted to build a system, build a model. So we had at this point this sort of the SUPR, the susceptible, untested, positive, removed model that I described. But then we quickly realized that we can't make the approximations that you can justify for a large in the large population regime. You can't really justify for a small population, smallish population regime that an institution like UIUC belongs to, right? So for this, we had to come up with a little bit of a modified version of the SUPR, but roughly the idea is the same. I mean, it's not very difficult to assume to figure out what this would look like. If you're looking at the susceptible population, for example, again, the new number of infections is going to be taken out. Now, you can roughly think about, if you're thinking about a large country like United States, and with travel largely restricted from other countries, you can think about that as a closed population, a closed system, right? But you can't do that here, because we all live in the county that we are in. We are in Champaign County here, right? So we all have, we buy food, we go to grocery stores, we interact with, to an extent, interact with people outside of the institution to an extent. So we looked at, essentially, here is the portion that accounts for new infections emerging from contacts within the institution. This is outside the institution. So this is one respect, for example, how this model differs from the previous one. So for this particular work, that what we wanted to understand is, let's adapt our SUPR model to this setting. Then again, this is a compartmental model. Again, it's not going to give you exactly the 4 to the n Markov chain. This is not an analysis of that. So this is obviously a simplification. So from that compartmental model, we use data to do parameter estimation from not just UIUC, but many other universities which have at least some testing programs. And from the estimated parameters, rather than just looking at the compartmental model and how it would behave with these different parameters, we wanted to do agent-based simulations. The reason is, agent-based simulations, as you decrease the size of the population, the efficacy of a mean field in explaining infection dynamics gets lower and lower, right? So you might want to look at agent-based simulations where this inherent stochasticity or the randomness of this process might affect you more. So if you were to design any sort of quote unquote policy recommendations, it's plausible that we might want to think about agent-based simulations, look at even parameters that are somewhat, you tweak the parameters over a wider range and see what happens, so that we don't make mistakes in terms of sort of the conclusions we draw. To ensure robustness of your sort of the policy recommendations, it's somewhat imperative to do such simulations, right? Okay, so we set this up. So again, compartmental model, modified SUPR, data from UIUC SHIELD program and multiple other universities, more precisely 85 other universities. Then with those parameter estimates, you run agent-based simulation and then see what happens, right? So before we get into sort of the result of the parameter estimation, one of the things that we observed is that institutions, when you think about institutions and COVID dynamics within the institutions, you cannot think about them as isolated at all. Like, we modified this and the original SUPR to include this external infection as a contributing factor. Indeed, if you look at sort of the infection dynamics, you will see that the universities, the mean, the way they behave, and the county level positivity rates, they are not very different. Their trends are similar. In fact, if you plot them on a scatter plot, there is some positive, definite positive correlation, right? And there are things that you would be able to observe. So for example, there is a surge around October, November, right? This is like Thanksgiving break, US general elections, and even socio-political gatherings, which contributed to these kinds of surges. If you think about the university, it's actually, in hindsight, this is not surprising, right? But not just UIUC, some companies even approached us to think about how to, is there a way to sort of think about preventing the sort of spread of this disease within their institutions. One of the things we worried about is, can you really do that in an isolated, thinking of it as an isolated environment? Not really, right? Because there is this sort of a dyadic relationship between what happens within the institution and outside of it, right? In fact, I would even go so far as to argue that if you are in a university town, new students coming in, perhaps some of them infected from other places coming in, might even contribute positively towards the county's positivity rate. So, and the more people who are getting infected within the institution, they go to grocery stores, they go out, they can also quote unquote infect the external population, right? So there is this sort of a relationship. In hindsight, this is not surprising, but yes, data bears, shows exactly what we expected here. Then the question that the $1 million question that we wanted to ask, is bulk testing necessary? Is it somewhat that important? Whoever here are from UIUC, we are very familiar with these kinds of testing booths that were set up. I am testing myself twice a week at the moment to even get building access, right? So the question is, does the number of tests per the population of your institution, is that really important? So interestingly, from the data that one of our collaborators, Anton Ivanov, he set up this sort of getting all the data streams together from multiple different institutions. There is definitely some negative correlation with this, right? So the weekly test positivity does seem to go down when that institution is testing more um, uh, with respect to its population, right? Now, how much testing is enough? That's a question that one often asks. So we did this sort of agent-based simulations. Again, this is based on the parameters that you estimate from data. Over 50,000 population, it seems that, notice that, I mean, what this is plots is number of susceptible over time, right? And this sort of, with just 1,000 tests per day, there is somewhat of a quick decay, but this disappears as you go up to like 5 to 10 to 15,000 tests a day. So UIUC, mind you, is currently doing something close to or around 10,000 tests a day. So this is what even the data shows as being the right paradigm. Even through the agent-based simulations, based on with the parameters that we've estimated from data, this seems to be the right, at least the right kind of testing levels that we need. So if you just rough numbers again, 10,000 tests daily, 50,000 population, so it's 1/5. Is this sort of the ratio that you need? Well, we redid this sort of the simulations, or the credit goes to Ujjal for all of this agent-based simulations, and Sebastian. If you look at this with the 25,000 population, the qualitatively it is similar. Again, things start becoming much better once you get to around testing levels of 20% of the population every day. But that's quite a bit of investment. As I said, it's what UIUC has adopted is this notion of saliva-based tests, as opposed to sort of the nasal swab-based tests. We'll come to that a little bit. So, moral of the story, bulk testing to the level of 20% a day is seemingly doing much better than lower testing levels. What about contact tracing? Can contact tracing help? So we came up with a simple metric, average daily number of susceptible fraction of the population, right? So higher this number, this fraction, higher, if this is 1, then nobody ever gets infected, right? 0 means it's a catastrophic failure of whatever testing paradigm you've adopted. So higher the number, the better, right? So if you look at number of daily tests, this is all with 50,000 as your population. If you go from contact tracing efficiency, it's never even this high. It's difficult to institute perfect contact tracing. As I would argue that, yes, contact tracing with some efficiency matters quite a bit, but it starts mattering less and less as you increase and ramp up your bulk testing capabilities. This is not surprising again, because as your bulk testing the inefficiency of contact tracing, you can make up for it through bulk testing if you have a lot more capacity. And that sort of seems to be the case. There is a sharp drop from 90% to 80% efficiency with 1,000 tests. So contact tracing is much more important if you don't have bulk testing capabilities. But if you can develop bulk testing capabilities, the drop is much smaller, right? This is, again, not surprising. Now, one can ask, well, you want to do bulk testing. What about things like social distancing and mask wearing and putting in, let's say, these hand sanitizer stands at various places. Do we really need all this? Can we drop this and just use bulk testing as our means of controlling? Well, I would argue actually no. So let's suppose we have just 1,000 tests a day, right? With whatever the estimated beta naught here, if you look at this sort of the number of susceptibles decay much more gracefully here. But once you go make beta naught a little higher, which is the base transmittivity of the infection, it leads to a catastrophic failure of this process, right? Of the number of susceptibles. Now, of course, this degradation becomes better once you go up to 10,000 tests. But I would still argue that what the agent-based simulations show is that this base transmittivity is a very large contributing factor. I mean, this is not surprising again, right? Think about what this base transmittivity is. One susceptible individual meets one infected individual. What is the probability that you get infected? Mask wearing to social distancing, even staggering of schedules of classes and moving some to online. What this essentially does, it reduces the possibility of meeting as well as the potency of each meeting in transmitting the infection. So it sort of goes at the very heart of and sort of attacks the very heart of the infection transmittal process. So this is absolutely crucial. So all of these measures that we are instituting is very, very, very crucial to containing this disease. Now, the last one that I want to talk about is so this the testing paradigm that has been sort of looked at is this saliva-based tests with a turnaround times is very, very quick. As I said, I tested yesterday, and today morning I got the results, and as a result, I'm in the building at the moment, right? So there have been some concerns about what if there are false negatives. Well, there are test sensitivities are never perfect, right? There have been multiple independent studies that have been done that show that they are comparable to the one that is from nasal swabs. But let's reduce the test sensitivities. Again, let's do 10,000 tests daily. But let me add an additional factor. Let me add a gap between when the testing is done and when the results are released. Mind you, this difference is a time when, if you are someone who is already infected, you will be still mingling with others and infecting others, right? So the effectivity of a test reduces if the test results come out much later, right? So we try to compare this through our agent-based simulation. This is 0 days, 2 days, and 4 days of delay, and these are test sensitivities. So let's do the following exercise in this table. And again, we are measuring that average daily susceptible fraction. The higher, the better. From this corner, let's move our eyes to the right and then move our eyes to down, right? Now, if you look right, yes, there is a drop. That drop is much sharper than the drop that happens once you go down. Of course, within reason. Of course, if the test sensitivity is very low, then there is not, this test is somewhat useless, right? But if the test sensitivity is reasonable, I would argue that rapidity of the test result is actually crucial. It seems to be more important, for our simulations at least, more than the test sensitivity. So it's not just bulk testing, it's rapid bulk testing that lies at the heart of a good reopening strategy. I would, however, say that even with such testing paradigms, if the infection load in the county, the place where you're located, is very high, after all, we are in not a closed system, as I said, things are going to be, I mean, it is difficult to fully just look at your institution and be able to contain it. So these are multiple factors that affect, and we have tried to sort of analyze what the impact of the multiple factors are in this sort of a work. This work is on medRxiv. It's a working paper. So let me wrap up now. So what we've done is essentially come up with sort of this quote unquote new compartmental model to analyze the dynamics of COVID-19. By no means is this the only work that tries to model such a spread. There are the number of papers that have come out on COVID-19, the response of the of academia has been overwhelming, and it's hopefully that this has been able to help in some way. But our goal has been to sort of look at a model that is both somewhat reflective. It captures the essential features of the disease, but is somewhat amenable to some structural insights, right? And we have a bunch of ongoing work. Apart from the two things that I went into some detail, we are still working on some test site allocation problems, which we started with. Now we are looking for essentially these operational questions. You are in response to essentially the infection prediction, but in the infection prediction, can you do some social media content based sentiment analysis to be able to better inform your prediction, which then translates into better decision making. So that's one of the works that we are doing. The second is on hotspot identification. These are the locations that cater to the rapid growth of infections, right? But as you might imagine, it's time varying. So can you predict not just hotspots now, but the hotspots later with some lead time using a combination of data analytics and machine learning, etc. And the third one, which you may have imagined, we've only looked at two different mechanisms, right? Testing and lockdown. The other one that is on all our minds at the moment is this vaccination. Can vaccination be combined into this model, and you write one full model to see can you do targeted vaccination? How do you balance between vaccination, testing, and lockdown in being able to control the spread of this disease? With vaccination, there are lots of supply chain questions that you can start asking. We are looking into these. Now we've already expanded our team to have someone who's an epidemiologist, and hopefully at some point this matures into something that is able to perhaps, maybe not, COVID-19 gives us a way to model this in a way that we are prepared for at least the next onslaught. So with that, I'll thank our sponsor, C3 AI Digital Transformation Institute, and open up for any questions. Thank you.
Thank you so much. That's great. So we don't have questions in the Q&A yet, so I'm going to encourage the audience to send some, but I have some questions for you. So let me just start with one of them. How realistic is the cost of the epidemic that you have considered? So you've described that in a particular way. Can you comment on how realistic that is and whether or not you think of changing it in some way?
So it's an excellent question. So the thing about the cost that we have modeled, yes, it's a simplification, right? It has these components, perhaps death toll, hospitalization costs, economic consequences of lockdown. But if you think about lockdown, for example, suppose I keep things locked down for 5 days and there is some economic impact, and then I keep it locked down for 10 days. Is it just double, or it's much more, right? So currently it's a nice linear model that we have taken. Perhaps this is not that realistic, and we'll have to think about a more complex cost structures. But the goal of this work was not to get into such, to make a very complicated cost function, but rather to get some insights into, can we get some structural insights, even with something simple. The economic losses, mind you, have been amazingly high. So I was just reading today, it's to the global GDP has dropped north of 4%. Which is huge, right? So there are better models to capture that, perhaps. But even with something simple, can we show something interesting is what we concentrated on.
Okay, I'm going to let other questions. So
should I ask?
Yes, please do. Yes.
So that was a very nice talk. Thank you, Bose. So we had a talk by Nigel Goldenfeld was it last week or the week before in our annual research symposium. So he talked about detailed models of what's happening at the university, and he also talked about how testing and quarantining, what impact that has, and how that informed our universities, decisions to reopen and so on. So I was curious about, since you mentioned that you've had some interactions with SHIELD, I didn't know if you had some input into those models, or whether how your models are different or similar to what they're using, if you have some insight into that.
So, I mean, most of our interaction has been with Ron Watkins, who currently is the director of the SHIELD program. And we did have a conversation with the team initially when they were rolling out. But in terms of the models, we haven't directly compared them. No, we haven't.
Okay, thanks.
Are there any questions from the audience yet? In that case, I'm going to take advantage of having your ear and ask another question that interests me. And maybe Shrikant will have another one after.
Andy, there are 2 questions in the Q&A.
Ah, sorry about that. Okay, Dietlef Hull says, of all the parameters you listed, cost function seems to be the most sensitive to beta. Isn't that also the easiest and cheapest to reduce? F is expensive, but beta not?
I agree with you. And that's exactly the statement that I made through that. Beta is at the heart of the transmission, right? So suppose Shrikant is infected and I'm not, let's say. Sorry, Shrikant, to take your example, but suppose he's infected and I'm not. If we are both wearing masks, it reduces the possibility of infecting. Yes, it's cheap. Per person getting a mask is much cheaper, right? But F is much more expensive. You're exactly right. So at this point, given the hindsight of the fact that so much has been done, and yet we stand where we cannot open up the economy normally. I'm having to teach online. Most of us are. It remains that we need a multi-pronged approach. It doesn't seem like you can just get away with one, right? And that's what even the simple eigenvalue analysis tended to show.
Okay, the next question has to do with your slides. Can your slides be shared? I know they'll be on YouTube anyway, but are you willing to share your slides, or is there any sensitive data? Good. In that case, Raleigh Butler would love a copy. So just send an email to Professor Bose and you can get the slides. Okay. Are there any more questions in the Q&A? I think not yet. Okay, then I'm going to take advantage of you since we still have a few more minutes. How viable are the strategies that you're proposing?
In some form or manner, something of all the strategies that we are talking have been implemented in some form or manner somewhere, right? Even that thing about zigzagging between no lockdown and some lockdown, right? If I understand correctly, West Bengal's policy, it's Wednesdays, Saturdays, and Sundays are lockdown, and then you don't have any on the other days. This is what, is that viable? Is that not viable? I mean, we are living in a new normal reality at this point, okay. having to rethink everything from scratch. So I would say some form or manner, if it has been implemented.
Okay, so there's another question, by the way, in the Q&A, but I'm just going to say your response about that reminds me of the nonlinearity of the stress caused by lockdown. So having 3 days off and then 4 days down is not the same thing as on again, off again, right? But anyway, let's go to the next question. Diptendra Bakshi says, you talked about the university setting in a county, but do you have insight about the same kind of analysis at the country level, given that we're in such a connected world?
So the dynamics of, we looked at the county level, but if you look at that sort of the trend, right? Surge during October, November, you can see it in the national level of COVID as well. You'll see that same kind of surges during those times, right? This is at the time when there was Thanksgiving break, US general elections, and socio-political gatherings. So COVID transmission, it's not rocket science. You have COVID, I meet you, we spend enough time, I get it. If there are no precautions, it's as simple as that. There isn't rocket science. Unfortunate part of any epidemic spread, the disease transmission process, if you look at it, it's exponentially fast, right? So that's the problem, is it grows very fast. So the question is, your point is well taken. Even if you think about a county is not isolated. It is part of the neighboring counties. There are people coming in and going out. There are people traveling. So all of the data that you get from multiple different counties, states, and national level dynamics, they're not going to be too wildly different.
Okay.
Right?
Good. Shrikant, do you want to ask a question while we see if anyone else has anything to ask?
I just have a broad question, slightly unrelated to your talk, but since you mentioned West Bengal, I mean, India is far more dense in terms of population, but somehow, even though India is badly affected, it's still not in the same in terms of the number of infections per person or deaths per person. What is your take on it? What do you think is the reason?
I have been battling with this question for a while. let's say that, and I'm not sure completely in terms of the accuracy of the numbers, which I don't want to question because I don't know enough. But I've been battling with this particular question.
So I looked up some stats, and it says the average age in India is 29 and the average age in the US is 38. And the number of people over 75 in India is actually less than the number of people over 75 in the US. And I wonder if also in India, older people don't live together. I mean, there are no nursing homes. There are a few these days, but typically they live with families. So I wonder if those are factors. I don't know. It's kind of interesting how a model would take all those into account.
I do not know the answer to that, because I would imagine that the prevalence of the density of people and actions would make up for this marginal increase. So I do not know. I don't have a good answer.
Okay, there's another question in the Q&A from Raleigh Butler. It says, I know there are countries such as South Korea that took early action, and therefore the cost of dealing with the virus has been less expensive for them. Is there anything Champaign County could have done differently?
In general, with epidemic processes, as I said, they grow very fast. If you could nip them in the bud, then it's very easy. But if they grow too fast, then anybody who has dealt with any rate of dynamic processes, it's obvious that it's going to become a big problem once it goes out of your hand. So yes, Korea did an excellent job, and testing as a means of control. We were in fact to an extent motivated by that, by the way South Korea did this, and I
guess the answer is we should have just started a bit even earlier than we did, but otherwise, yeah.
Perhaps. But again, everything is 2020 in hindsight.
Yeah, that's true. Okay, well, I want to thank you so much. We're at the end of our hour, but this was a really stimulating and enjoyable colloquium, and it's nice to see you again.
Thank you.
Okay, thank you all. If you have follow-up questions, you can send them directly by email. Thank you.
Thank you.
Bye.
Bye.